Hello and welcome everyone. Greetings from Qatar. I'm Dr. SUHAIL YAQOOB, trauma surgeon working in the Department of Trauma, HAMAD General Hospital in the capital city of Doha. And before we start, let me introduce our distinguished faculty, which is sitting beside me. Dr. Sandro Rizzoli, the Medical Director of the Trauma Services, Dr. Ruben Peralta, Senior Consultant, Trauma and Program Director for the Critical Care Fellowship in Trauma, Dr. Vishy Verma, our Senior Consultant in the Critical Care Services of Trauma, and we're expecting our respected Head of Department and the Head of Department of Trauma and Vascular Surgery, Dr. Hassan Al-Thani, is going to join shortly in a couple of seconds. He's here. Dr. Hassan.
Good afternoon.
Good afternoon.
Yeah,
You're first.
You can introduce. Thank you.
So today we are going to talk about one case of stab wounds and assault, which created some decision-making difficulties in the time of resuscitation and then when we had to go for a surgical intervention. Let me again introduce our respected Head of Department, Dr. Hassan Al-Thani, Head of Department of Trauma and Vascular Services. He's going to present the case partly with me since he was the surgeon who intervened in this case. Okay, so the title of the case is Double Trouble, Which Way to Go? We have no financial disclosures. Regarding the patient, this case was an assault case with the injury time at around 8:20 hours in the morning, and the AMS was informed and they were by the patient's side by 8:50, and the information which was relayed to us, the trauma room, was at 9:10 in the morning. So we were informed that there's a case of multiple stab wounds. There was blood seen on the site at the site of the scuffle. The patient had hypotension, which responded to their intervention, and the pre-hospital vitals which were conveyed to us was that the patient had a respiratory rate of 55 per minute, a systolic blood pressure of 90 after resuscitation, and a heart rate of 130 per minute with a GCS of 9. Trauma team was activated according to the vitals and the information provided to us, and in view of the COVID times, we took our adequate precautions. The patient was received in the trauma room at 9:40 hours. When we initially assessed the patient at the time of handover, we found that the patient was restless. He was agitated and diaphoretic, and we noticed that he had one IV line in the left hand. The endorsement given by the EMS was that 500 ml of normal saline was given, 30 milligrams of ketamine, and 1 gram of tranexamic acid. The quick primary survey showed that this patient needed an intubation because his airway had to be secured. Breathing showed that it was tachypnea with a rate of 40. Chest examination was unremarkable because the air entry was bilaterally equal, the sounds were resonant. Saturation was hovering around 92 to 94%. Manual BP, which was checked at that time, showed that the systolic pressure had fallen to 70 millimeters of mercury. Heart rate was 140 and the GCS was 9. The endorsement given to us and from the dressings which we noticed on the patient, we saw that there were grossly 5 wounds, actually, 4 on the front, 1 small on the back. There were wounds on the left interior chest, which was a small puncture wound, probably 2 centimeters in size, which was oozy. There were big wounds, 5 to 6 centimeters on both the arms, and which were covered by dressing. They were not actually bleeding. There was one wound of concern in the right flank, posterior axillary line, which was quite big, 5 to 6 centimeters, minimally bleeding, but no sounds added on that wound. These are the reconstructed images. This was the right flank wound in the posterior axillary line. This is a superficial scapular wound on the back, exactly on the spine of the scapula. So the house is open for discussion.
Sao Paulo, Dr. Tele, your comments, please.
Yes, at this moment, I believe this patient is unstable. His need, we usually here you go to make transfusion, massive transfusion protocol, start with this patient. In these patients, I have a wound in the chest, a wound in the flank that may be problems. In the wound in the chest, sometimes maybe injuries of the mediastinum or maybe the heart, maybe the pleura. So if the patient is continually stable, I need an X-ray of this patient to see what's happened, or examination of the chest can see if can signs of cardiac tamponated or there is fluid in the chest, so pleural effusion. The problem is that the injuries in the flank sometimes very difficult to know if it's penetrate or not penetrate in the abdomen, and maybe injuries in the abdomen. So the patients may become stable, says hypotensive, tachycardic, diaphoretic. So I believe these patients need maybe to check the chest, check the abdomen, maybe an ultrasound, maybe sometimes it's not very good ultrasound for penetrating wound. So sometimes the patients have times I go to make or a CT scan of these patients, or they go to an operating room. This become the hemodynamic stability of the patient. So in these situations, I go to please to check the chest, start massive protocol transfusion, and go to see what's the hemorrhage surrounds. I believe maybe in abdomen, maybe in chest. So it's very difficult to know where if I have to approach to control the surrounds. I need to know where is the most important blending area or multiple surrounds. So I need sometimes I need some exams, or if the patients decide by me, by maybe a cardiac arrest, I go to a thoracotomy at this moment. That's the way I go.
Thank you, Dr. Tele. In Dover, Dr. Alex, your comment, sir.
Good morning. So difficult situation here with, you don't know exactly where the bleeding is from. I would do, so I agree with the massive transfusion protocol. I would do the fast first, and I would look at the heart. If I don't see any pericardial tamponade, then I'll continue my search. Maybe even put the probe on the abdomen. You may see fluid. I don't know if the patient had any abdominal tenderness before the intubation. That may help you identify and help with the source. And I would get a chest X-ray to help with identification of a massive hemothorax. That can be done fairly quickly.
Thank you very much, sir. In India, Dr. Venkat.
Good morning. This patient is quite unstable now, and what we can do is activate the massive transfusion protocol to start the resuscitation and massive transfusion protocol, and then at the same time we have to go for an extended fast, look at the chest, that is the chest, then pericardium, and if there is any pericardial tamponade or any pleural effusion, hemothorax. So that's what we need to look in, and then see at the abdomen also, just to make sure where exactly the patient is bleeding. And depending on the site of the bleed, I think that actually dictates what to do next. So it's basically resuscitate at present and do an extended fast to look at any pericardial tamponade. And if there is definitely any pericardial tamponade, probably that needs an exploration without any further imaging. But if there is no pericardial tamponade and it's only, it's only something like abdomen, then we can go for a CT for both chest and abdomen later. But it definitely depends what are the findings on the extended fast. Thank you.
Thank you, sir. In Portland, Dr. Kasim, your comments, please.
Well, you had the luxury of communicating with the EMT before the patient was brought to the hospital. So you need to be prepared for that. So the first thing I would do would be to have blood available, even if it is O negative, and also have a chest X-ray available immediately when the patient comes in. You have intubated the patient because he was agitated and restless and probably combative as well. So once you intubate the patient without knowing what his respiratory status is, then you are in a bit of a dilemma. Obviously, the two injuries that I'm looking at here is the two cavity. One is the thoracic cavity in the left anterior chest wall, and one is the flank injury. But I will not ignore the stab wound in the back and near the scapula. So indeed, he has two stab wounds to the chest, one in the abdomen. So you have two cavity injury here, and you need to think about what you're going to do, which cavity is causing all the problem. Massive transfusion protocol is in order. Patient is hypotensive, tachycardic, as well as tachypneic. Why he is so tachypneic is a puzzle at this moment, and that needs to be elucidated a little bit. So an orderly approach to this patient will give you some answers, and then we'll go from there. Thank you.
Thank you, Dr. Kassim. And Ryder, Dr. Post.
Yes, good morning. As the prior speakers already mentioned, obviously this patient is profoundly unstable and class 4 shock. He's very hypotensive and he has an altered mental status. And we have to quickly figure out what's going on with him as the other speakers mentioned before. And one thing is obviously shock from blood loss, and the other thing is shock from tension pneumothorax or cardiac tamponade, or the combination of all of them, right? We don't know. We have all those, the mantra here at the right, stable patients get workup, unstable patients get treatments. So based on ATS protocol, if you have a right side thoracoabdominal gunshot wound on the patient who is dead unstable and hypoxic and tachypneic, you have to assume that he has a tension pneumothorax on the right side. And you have the stab one on the left and the back, which could also create a pneumothorax on the left side. Now, if the scapula, avoided, if it's directly over the scapula, it's unlikely that it went through. But if it's a little bit lateral to the scapula or medial, it may have passed through and you have an injury in the left chest too. As you mentioned, you can use the FAST examination and look at the lung and look for lung sliding. You can listen with your stethoscope. However, if in doubt, you put a chest tube in. And I think that's what you did, because I saw one of your pictures already had a chest tube on the right side. The chest tube also gives us some diagnostic information as well, because we can see how much blood is coming out, right? And then if the chest tube on the right side is putting out a significant amount of blood, we have to think about, okay, is this coming from a lung injury, or if this is coming from a liver injury bleeding through a diaphragmatic laceration into the chest? So that's where the dilemma comes, as the other speakers mentioned already, which cavity first, and I think that's where we're gonna head next. And the other thing is as Alex already mentioned, we always want to rule out also cardiac tamponade. And regarding the intubation, it's always very difficult to deal with combative patients if we don't intubate them early. But if possible, we always try to get some volume in to improve the venous return to the heart and rule out tension pneumothorax, because, if we intubate them now and go on positive pressure ventilation, we're changing the intrathoracic pressure system, right? And the patient may arrest if they're very hypotensive already. If they're already like very hypovolemic, they may arrest on induction. So always try to get some volume in before we induce anesthesia, if possible at that time. That's what I have to say. Thank you.
Thank you, Dr. Post. Does anyone have another comment before we return to our presenter?
Yes, Gary, just to reemphasize what Dr. Kassim said, it's very important to have a trauma center and trauma system to have information from the pre-hospital. So, and I know this is very well established in Qatar. So, center receive information, the patient hypotensive, blood is immediately available, and the resuscitation starts right away. And also in this situation, this is the worst kind of injuries in the thoracoabdominal region. Like Dr. Puss said, you don't know if there's bleeding in the chest, it's bleeding on the abdomen through the diaphragm and going to the chest. And even should always exclude a cardiac tamponade, or it may be even be bleeding from the heart to the open pericardium, going to the chest. So multiple things could be happening here right now, and if the patient is unstable, we need to work fast on this patient.
Thank you, Dr. Marttos. And if we have no more additional comments, we'll return to our presenter. Go ahead, Dr. Yaqoob.
Yeah, thank you, Gary.
Yes, sir.
And thank you, everybody, for those knowledge and informed comments. So we did respond to Dr. Kassim's thoughts, and we started the patient on resuscitation and blood. But while everything was being done, we did a quick e-fast, and we found that the right upper quadrant showed a very thin rim of fluid, hepatorenal area, and the pararenal area showed some hyperacoustics, which were suggestive of a hematoma. And keeping in view of the stab in the flank, we were thinking of retroperitoneal injury as such. And the IVC appeared to be slit-like. Again, a confusion between underperfusion or an injury to the IVC itself. But it did not show anything in the lungs. There were no signs of pneumothorax or any hemothorax. And the pericardial cavity was good. It was not showing any collection at all. So we started the transfusion from the left-hand side, the IV line, which was already inserted by the EMS, and we activated the MTP. During that time, preparations were made for RSI intubation with the box in these COVID times. And we were trying to secure other IV lines, right arm and right IJV after the intubation. And during this time, we transfused around a liter of normal saline, and bilateral chest tubes had to be inserted, but there was no output from the chest tubes. So after 2 units of PRBCs, we found that the systolic blood pressure rose up to 123. Heart rate came down to around 115. All peripheral pulses were felt. The anterior chest wall was found to actually ooze by this time. We just applied a pressure dressing on it, and during this time, abdomen was examined. It was soft, it was flat. DRE was negative. Foley's and OGD were inserted. It showed a clear output from these sites. This was the X-ray done immediately after the intubation and the insertion of the line tubes. Didn't show any significant injuries except for a small haziness in the left mediastinal area, but nothing grossly abnormal.
You already have a central line also.
Yeah.
That is like
Yeah.
affiliation.
Yeah, the central line in the right IJV. So by this time, the initial ABG comes back. We have a pH of 7.03, lactate of 8.5, bicarbonate of 13, and a base deficit of -17. Hemoglobin was maintained around 13.5, saturation 96%. We also did a rotum, showed a mild derangement of the intim, otherwise normal. So, Gary?
Okay, let's ask that question, Dr. Kassim, important.
Very interesting case, and so far very well managed, I would say. So the things that I would like to comment on is you don't want to get the blood pressure to 120. In a trauma situation, it is much better to have a blood pressure around 90 when you know something is bleeding somewhere and you're not sure. So that's my first comment. Second, now you have reasonably stabilized the patient, and you want to know which cavity that you want to find out where the patient is bleeding from. I think this is the time probably, like Dr. Collet will say, that he would send the patient for a CT angiogram to get an idea what the aorta looks like and the nominates looks like. And also you'll get some idea if the IVC is injured by the penetrating wound. I doubt very much because, like Dr. Yaqoob says, that it was IVC was more like, it looked like more like hypovolemia than a penetrating injury. So I think the next step would be to send the patient for CT angiogram to look at the aortic aorta as well as other vascular structures. Thank you.
Thank you, Dr. Kassim. India, Dr. Venkat, your comments, please.
Yeah, now the patient is relatively stable. So now he needs further evaluation to know the exact site of bleed. And from from the chest, what we have done earlier doesn't seem to be anything major within the chest as such. Probably we don't know where exactly. Still there is some ooze there, and with the pressure it has stopped. So we don't expect to be a major vessel injury in the chest. Probably, so this is the time then we have to go for CT angio. I agree with that we need to go for CT angio. Thank you.
Thank you, sir. And Dover, Dr. Alex.
Yeah, so that's very interesting. The lungs look pretty good. He could have had a tension pneumothorax that, explain his hypotension, and that was taken care of by the 2 chest tubes. But he's still acidotic. He still has a high lactic acid. The shape of the heart on the X-ray looks that is, still an empty heart, and he's probably transiently responder from my standpoint right now. And again, you have to see how is your facility set up. If you can just roll through the scanner on the way to the OR, fine, you may choose to do that. I would go to the operating room and focus on the abdomen, because it's probably bleeding in the abdomen. Thank you.
Thank you, Dr. Alex. Miami Ryder, Dr. Post.
Yeah, so it's a great case and great management so far. I think the bilateral chest tubes are very important because you demonstrated that he's not exsanguinating from the chest. And you also did not found a tension pneumothorax. And so the money here is really in the abdomen. What concerns me is that the patient was profoundly hypotensive and class 4 shock, and that you have severe acidosis. So that tells me that he lost at least 2 liters of blood, right? To get to those numbers, 1.5 liters, 2 liters probably he lost. As Alex mentioned, he responded, his blood pressure came up, but he's still tachycardic and a heart rate of 120. In my mind, there's nothing else to do but go to the operating room and do an exploratory laparotomy at this time. I don't think that the CT scan is going to add anything. When we do the trauma ELAB, we're going to look at everything. So, as trauma surgeon, we should find all the injuries on exploration and don't require a CT scan to know beforehand what's injured in the abdomen. And it costs time. And what could happen also that he gets hypotensive again in CAT scan, right? He may have responded right now. Now you roll to CT scan, and then the next blood pressure on CT scan may read 80 again, and the patient may still be actively bleeding, and we're spending 20 minutes on a CT scan when we could be in the operating room stopping the bleeding. So this patient came in very unstable, for sure lost a lot of blood. It's gonna be in the abdomen because he put in chest tubes and he's not bleeding from the chest. So I agree with Alex. I would go straight to the operating room and not go for CT scan. Thank you.
Gary, I have a question to the doctor. Do you take into consideration his hemoglobin was 13.5?
No.
Yeah.
No.
When you bleed whole blood and you transfuse blood, and we don't use a lot of crystalloids, I don't really expect his hemoglobin hematocrit to significantly go down in the early phase. So I don't. What I look is at hemodynamics and the base deficit, and what could have caused him to be so hypotensive and so acidotic. Right, a pH of 7.0, that's a life-threatening shock. And obviously there must be major injury to get to those kind of numbers and status of the patient. So we know it's not some minor thing. So, I don't think anything would change my management here if I get a CT scan on this patient. Thank you.
Thank you, Dr. Post. Does that satisfy your question, Dr. Kasim?
Yes, it does. Thank you.
Very good. We'll go to Dr. Marttos and then Dr. Tele. Dr. Marttos?
Yeah. So I think this is the patient that's really dangerous. It's a dangerous situation because the patient responded to blood, but I don't know if he's going to be a full responder or a transient responder. At this point, I always teach my residents that you cannot say the patient is hemodynamically stable, because to say somebody is stable, I need you to watch the patient over time, need a movie. At this point, I have a picture. I had like at this moment he responded, but I don't know if in the next 5 minutes he's gonna stay hemodynamic normal or he's gonna deteriorate again. So I would say in a regular trauma center or in a regular hospital, this patient should go to the operating room. But at some trauma centers, we could deviate a little bit the protocol. In my hospital, what I did a couple of times, the patient normalized the blood pressure. And since the CAT scan is very close to the operating room, a couple of times I place arterial line, so I have a full control of the blood pressure. I could go into the CAT scan with blood with me. So if something happened in the CAT scan, I would quickly go send the patient to the operating room. It's like being continuation resuscitation in the trauma and in the CAT scan. I can do that. But these are deviation of protocol. I know that in Qatar, they have the CAT scan in the operating room altogether. They have a nice hybrid room, and they have CAT scan and interventional radiology altogether, angio, etc. I think they could deviate the protocol because they have the resource. But Dr. Puss is correct. So in a regular center, the way you teach your residents or this patient need exploration, because you didn't find anything in the chest cavity. But in some special place which experience trauma staff and all the resources available, like I know they have at the HAMAD hospital, they could do these things, manage this a little bit different, and maybe stop by the CAT scan or before the surgery. So I'm very curious to see what did they.
Thank you, Dr. Marttos. Dr. Tele, sorry about the delay. Your comments.
No, okay. I agree with all comments. In these situations, I have two options. If I have the patient maybe becomes not stable, because you can see the blood gas, the patient is acidotic. So I believe that the patient is not stable. So the patient may be a transit response of the reposition. In these situations, in the hospitals, clinics, you have a CT scan near the emergency room, so I can try to take a X-ray, a CT scan, angio CT, to see the injuries if possible. In other hospital that I work, there is no possibility to make an angio CT, so in these situations I go to the OR and start with a laparotomy. It usually depends on where you are. So I believe that's a very important comment, that is. And I'm very afraid when we're in patients with penetrate injuries, when we start to the blood reposition, you can enhance the pressure, but you have to be careful when you enough the pressures, because you can detamponate the injuries, so you can start bleeding again. So you may be in these situations, you can be very careful with the pressure of the patients and the reposition until you have to control the hemorrhage rounds. Thank you.
Thank you,
Gary, just adding a comment. So I had an older professor, a very well-known professor in Brazil, Dr. Birolini. He was the professor of the professors, and he worked with Dr. Collet. So I used to say the only trauma patient that can for sure say his hemodynamic stable in the first 10 minutes of resuscitation is the patient that is dead. Because this patient know that they're not going to change the vital signs. All the other trauma centers, you cannot assume they are stable until you follow the patient over time.
Yeah, one more comment from me, if you mind, 1 second. Also,
yeah, be my guest. Go ahead, please.
There's we're very well aware that different centers have different setups and different philosophies, and there's no right or wrong here, I think. And every case you have to look at it case by case and the situation, how you set up and so on. I know other centers, even in Germany, my home country, a lot of hypotensive trauma patients go to CAT scan and get scanned. Some hospitals have a CT, the resuscitation bay is a CT scanner basically, right? They do it, their resuscitation, the CAT scan area. So it's different setups. But one thing we have demonstrated here in one of our studies, we looked at time to the operating room in gunshot wound patients, hemodynamic unstable gunshot patients. And there is a correlation with time to the OR and survival. So as faster we reach to the operating room and start incision, as better the survival gets in that patient population penetrating trauma with gunshot. So again, this patient came in very unstable, it's a penetrating trauma. So I think that time to control of hemorrhage is important. And even in the best hospitals with CT scan immediately available, it takes time to get a CAT scan, right? It's not a 2-minute examination. We always say it's 2 minutes to get a CAT scan. And really, you have to transport the patient where we have to put them on the scanner, secure them, set up the IV contrast, prime the CT scanner. I mean, it takes 10, 15 minutes at least, right? And that's 15 minutes where the patient is bleeding. And, you know, if you have a renal artery injury is bleeding from it or from the cava, 15 minutes is a long time, and it may make the difference. So there's no right or wrong here, but, you know, we have to look at every case and at every facility, just as Dr. Collet said. You know, some areas it's possible to get a quick CT scan, and if you feel like it gives you extra information in what cavity to go and so on, sure. I think with this chest X-ray and those chest tubes in place, not bleeding, I think we can be pretty confident that the problem is in the abdomen. Thank you.
Thank you, Dr. Post. At this time, there are no more comments. We'll return to our presentation.
Yeah, thanks for those comments. Now, the patient suddenly deteriorates. His systolic blood pressure falls to around 55 millimeters of mercury. Heart rate stays at around 120 per minute, and saturation is still maintained. So while we are contemplating where to send the patient to the CT or the OR, there is a knock on our door, and we have to take a call. We surveyed the patient again quickly. Abdomen still was flat. Chest tubes did not bring out anything. FAST was repeated, again the same findings. So now what happens that we noticed that there's a bulge on the anterior left chest wall, and the pools has started to become copious. And we make a decision to go to the OR, and meanwhile we call the vascular team for a possibility of major chest vessel bleed or an IVC injury. And we take the patient to the OR. The vitals in the OR are 80/50 blood pressure, heart rate of 120, saturation maintained at 100%. So we have another dilemma, what to do. Do we go for a median sternotomy? Do we go for a left thoracotomy, a laparotomy, or a primary wound exploration? Yeah.
Now it's bleeding on yourself.
Yeah, so I'll show you. The point of injury was somewhere here, left parasternal, and it was a 1 to 2 centimeter size wound, and initially bleed oozing, and now there is a bulge, and the wound is bleeding copiously.
Yes.
So now Dr. Hassan, vascular surgeon and head of trauma, he takes over from here in the operating room. Yeah.
So thank you very much. So I'm called in the middle of this mess, and as you know, you heard the finding. The patient has palpable pulse. He had 1 liter of normal saline through the left hand, and he has a central line on the right internal jugular, a big sheet. He has bilateral chest tube, and he started to have deterioration as they were resuscitating him. Now blood pressure is 80. His chest tube is not draining anything, and he is in the operating theater, and already they took the decision of the 4th decision in here, exploration of the wound, which is in the anterior chest wall. So my thinking process whenever I come to a hemorrhage in the operating theater that I didn't see, I always tell my resident, and I'm just repeating this, is this compressible or non-compressible hemorrhage? And we know that non-compressible hemorrhage is the disaster. And I always have an algorithm for the resident, and this is the algorithm. So when it's come to non-compressible hemorrhage, I always think, can we put a pressure tourniquet, put something on this, or ligate the wound before we go in? And if it's non-compressible, can we do topical hemostasis? We need ER laparotomy, ER thoracotomy, or endovascular. And I timed the slides so I don't spend a lot of time because this is, too much. And the endovascular, we have a hybrid OR, and the hybrid OR, we can do a CT scan, we can do actually angioembolization or stenting as required. The problem with the COVID we set the OR currently that 2 rooms are for COVID patient. That's not the hybrid OR. So we have to make sure, you know, that the patient in a hybrid setting in order to do this. In this patient, he was in a COVID room. So the maximum we can do, we bring a CR. But anyway, now I come to the room, the patient, and this is a CT scan post-op. I'm just going to put it there in order to show you where the incision was made. This is the outline of the incision, that the mark there. And I'm told that he has bleeding, active arterial bleed coming from the lateral aspect of the left chest. They are exploring the wound. They did not reach now to the intrathoracic area. And the suspicion is this is left subclavian artery injury. So my thinking process, where is the penetration? And I was, you know, told that it is in the anterior chest wall, but he has also in the back of the scapula. There is also on the right side. So I do think about how to explore him. Thoracotomy, sternotomy, supraclavicular, infraclavicular, or where to go. Or is this actually axillary and they missed it and therefore I just need to extend the wound? Until now, I am not sure where I'm going. And the other thing, what is the trajectory of this knife? Is it going from lateral to medial, or is it going from medial to lateral? That's something we have to think about also. So the decision was, let's continue with the exploration of the wound. And that's what actually we did. So we tried to manage to go to extend this one infraclavicular and have a direct pressure on the subclavian artery. Because subclavian artery, as you all well know, it is, I call it the junctional, you know, bleed. It is not external that you can put a pressure on. If it's inside, you know, the zone 1, and it is inside the, you know, the cavity if it's proximal. So it is a tough area to explore. So after we did this and we extended the wound, you can see that the patient was actually bleeding from the proximal part of his, So the patient, I'm sorry about this. So the patient was bleeding from the area just inferior, or the first part of the axilla here, the pectoralis minor, you know, proximal part of it. We managed to put a pressure here direct, so we managed this one, and then I extended the wound lateral. And it gave me an idea now of why the patient had sudden bulge in his chest. He has complete transection of the axillary artery, but also the axillary vein. So when he had all the crystalloid going through the left hand, most likely the clots on the distal part or the proximal part of the vein open up. The second thing, when he had the clots in the proximal part of the axillary artery, with the blood pressure going up, he actually dislodged that clot and he started to bleed. So had a combination of venous and arterial massive bleed from that area. But we managed to put a pressure on this area, and we identified that he has also one of his brachial plexus component is transected with it. So that's what we did. And the principle, I'm not, you know, this is for the resident. I know you are expertise. So these are the principle how we actually do an arterial repair. But the question that I want to know whether you use shunt in these patients or not, and what type of shunt you use. So this is a time-based slide, so it's running very fast. And I'll keep it open for you. We can skip this. Now.
So after exposure of the chest wall, and like Dr. Hassan said, after controlling the bleeding, the
Yeah. One there.
So a question is put. So what do you do now? Do you shunt? Do you repair? Do you ligate? What are the options here?
In India, Dr. Venkat, your comments, please.
I didn't get what is happening. Like now that this injury has been exposed and the vaginal vessels have been found injured, and they are being repaired using a graft. So that's fine. I mean, for anything, I'm not sure what want from us. I think that has been repaired already.
No, not. Sorry, the question is, would you actually shunt the patient as a damage control surgery while you are doing something else? And if you do, what type of shunt? If you don't, what's the steps that you will take as a trauma?
Sorry, I'm a gastrosurgeon actually. Probably I'll just involve my vascular surgeon. I'm not very sure about what to do.
Excellent. That's fine. No, that's good.
Thank you.
That's an excellent answer.
Okay. All right. Thank you, Dr. Venkat. And Ryder, Dr. Booth?
Yes, I would like to go back to what Dr. Kasim said. He mentioned earlier, you don't want to have a trauma patient on intensive. So what really happened, right? He was hypotensive, so he stopped bleeding from his subclavian artery. And once we started the resuscitation and the blood pressure came up, it popped open and he bled from it. And in the same side, it also kind of gave us the diagnosis where to go. Now, the people who would say, well, if you would have gone to CT scan, we would have found the injury. That's correct, right? You would know now that you have an axillary artery injury. And you would know if there's something going on in the abdomen. We still at this point don't know if there's something else going on in the abdomen, because sometimes our mind goes like, look, we found this axillary artery injury. That's where he bled from. That's where he's hypotensive from. But we haven't ruled out yet a second injury, right? We don't know yet still what's going on in the abdomen. So with that being said, we are in the operating room now, and I think we still are obligated to rule out major injury in the abdomen. In addition to this axillary artery, you already control it. It's a fantastic case. So regarding repair, I think it really depends on the status of the patient, right? If the patient now is stabilized after you put a clamp on the axillary artery and he responded to transfusion, is doing well now, and he has no other injuries, you could go ahead and repair put your graft in or a vein, whatever you decide to use. If the patient is still unstable, I would shunt it. We use Argo shunts here, and then I would explore the abdominal cavity. I may not find anything in the abdomen, but I think we have to keep in mind that there may be something else going on in addition to the injury you just detected and very nicely controlled. So I'm curious to see what else is coming. But in general, if the patient is stable, we do repair. If it's unstable, we shunt. Thank you.
Thank you, Dr. Post. Sao Paulo, Dr. Tele, your comments, please.
I agree with the comments first, because the patients if the patients stay unstable, I put a shunt. If the patient is stable, I can try to reconstruction the artery. And sometimes the reconstruction of the artery, in this situation with a stab wound, maybe if the artery is nice, is not too damaged, you can make a primary repair. If the artery is very damaged, you can make a shunt, a saphenous shunt. In the great problem, you have said that the patients have brachial or axillary vein and artery injuries. You have two injuries. And when you put two injuries, usually the reconstruction of the venous is very difficult. Sometimes may evolution of a venous hypertension. So the patient may become edemas of the member, and maybe a compartmental syndrome may become. So sometimes in these situations, you can, the reconstruction may become very difficult, and the complications may become later. But in these situations, in the acute moment, I try to reconstruction all of them, and maybe a fasciotomy. If I remember that what the Dr. Prost that says, that the patients may be injuries in the abdomen. So we can avoid, because there is a secondary hemorrhage surrounds. So I can have to be very quickly to control all the hemorrhage surrounds in these patients. So for this situation, I can win. I have to tell you something important sometimes here. I have a friend of mine that usually in subclavian artery or axillary artery in this position, and there is no, the injuries don't go to the chest, to the pleural cavity. You can put a Foley catheter through the wound and insufflate the balloon. Sometimes you can control the hemorrhage temporarily, so can gain enough time to go the surgery. Thank you.
Thank you, sir. And Dover, Dr. Alex, your comments, please.
Yeah, so that access in the right IJ was a very good choice for transfusing the patient and giving volume. And obviously the blood pressure going up popped the clot off, and the patient became again hypotensive. So, you know, going to the OR was a good thing. With regards to the situation now, if the patient with clamps on the axillary artery is hemodynamically stable, then you can have, you know, the time to, you know, go ahead and repair the axillary artery. It's usually friable and soft, and probably a piece of PTFE with rings. That would be my choice. If the patient is unstable, then if you're a rider, you may ask for like a second team, come and take a look in the belly as you're shunting or repairing. Or if you're just by yourself, then put an Argyle shunt, you know, 12, 14 French, whatever, tubing fits over there. And then you go in the abdomen and see where the patient is bleeding from and what else needs to be addressed. And then with regards to the last point here on the slide, the fasciotomy, it would be a decision based on how soft the compartments are and how much time did all take, and with regards to ischemia reperfusion. Thank you.
Thank you, Dr. Alex. Portland, Dr. Kassim.
Remember that we are approaching this patient with 2 cavity injuries. So we have identified a bulge in the anterior chest wall, and we have explored that area and found transaction of the axillary, proximal part of the axillary artery, and possibly injury to the vein as well. So in situations like this, and I have dealt cases like this with gunshot wound. I have never had a stab wound in this area, lucky for me. So I usually approach it transverse incision, remove the clavicle, and get access very quickly. It's a matter of just minutes to get access in that way. And I can identify all the vascular structures. And initially I will put the shunt in and watch and to see how this patient is doing hemodynamically. If he's getting stabilized, knowing that I have approached this patient as a 2-cavity injury, while the shunt is in place and everything is working good, I don't have any problem in doing a mini laparotomy at that time and having a look to see if I missed anything in the abdomen. And I can close it up quickly. And I'm sure Dr. Coley will do a laparoscopy because he's very good at this sort of thing. But I'm very good at open laparotomy. And then I can, if there's nothing going on in the abdomen, close it up and then make a decision what I want to do after I have perfused the arm with shunt in vein as well as the artery. And I most likely will use what Dr. Alex has advocated, ring PTF graft. And the vein, if it is a lateral tear, I would do a venopathy. If it is not, I will try very hard to repair that vein because I don't like my patient to have a swollen arm postoperatively. And regarding fasciotomy, it is my practice to do prophylactic fasciotomy in this patient because I have been burned a couple of times. Thank you.
Thank you, Dr. Kassim.
Gary,
Go Go ahead.
Is that okay if we, just because of the time, is that okay if we take over once again?
Yes, sir. It's your presentation. Go ahead and tell me
Thank you very much.
if you want to proceed. Go ahead.
Thank you. So regarding actually this patient, shunting is I put a lot of shunting for a patient who's coming with a complex arterial injury and other injuries in order to give me a time to do the damage control for the other part. As you stated, you have a two cavity that we are not aware of what's happening, and also he has venous injury and nerve injury. So I usually put a shunt, and the shunt I use because I am in a setting that I do vascular cases. I use a Bruton-Hara shunt. The reason I use a Bruton-Hara shunt, it gives me access to the proximal artery and distal artery, so I can actually infuse heparin locally and also heparin saline if I need. And it also gives me a shorter ischemia time for the distal limb, and therefore I don't need to do fasciotomy if that limb, had a shorter ischemia time. So a Bruton-Hara shunt in my practice is common than, Javits shunt, but Javits shunt is fine. The problem with that, you cannot flush the artery proximally or distally as you proceed with your case, and therefore you are limited to the access of intravascular lumen. So when we put the Bruton-Hara shunt, we gave hep saline distally. We made sure that there is no clot, and there was a clot distally, so pasta Fogarty catheter, clean it, put the shunt, and then we made sure that the flow is maintained. This also gives me actually the chance that now the vein start to bleed distally, so I know where is the proximal part of the vein and how to control the bleeding from the venous system, and also to give me a chance to repair it when the flow continues. So if I clamp the artery, or the vein and repair, then it will have an issue, especially that I'm worried that this patient will bleed in other cavity. I cannot give him a systemic heparinization. While actually the team the other team, the trauma team is there, so I start harvesting a greater saphenous vein, and the team started doing EFAST again. So they checked the abdomen with ultrasound intraoperatively, and there was no change in the free fluid in the peritoneal cavity, and there is no change in the right side of the chest. So proceed with repair of the vein, repair of the nerve, and also repair of the artery with interposition, a greater saphenous vein, and we put a drain in the area, and the patient went from there to the CT scan for a full pan CT in order to make sure that we did not miss any injury. The question here that I will raise, do you give anti-platelet, you give heparin or warfarin post-op? What type of anticoagulant or antiplatelet would you advocate in a trauma setting? That's maybe something from Oscar.
And then if it's okay, can we just make a quick run around and see what would you use after a repair like this? Would you give an antiplatelet, and would you anticoagulate the patient? What would you do?
Thank you. As Team QATAR indicated, being aware of the time, please try to give the brief comment as you possibly can.
So actually post-operative in these cases, I follow the preferred vascular protocols that we have. So we give a dual antiplatelet. There is no solid evidence to support this from a trauma point of view, but after the pan CT showed no finding in the abdomen or the chest, apart from what we found, the patient was kept on a dual antiplatelet, and the patient was discharged home, came back with partial thrombosis of his axillary vein, but patent, and he is in a COVID quarantine hospital. So the family physician who's looking after him want to start the new anticoagulant, oral anticoagulant for this patient. And in my opinion, that this patient actually, the partial thrombosis was ligated the tributaries of the axillary vein rather than a real clots, because the axillary vein itself was patent. And there is no evidence to support giving a new anticoagulant for a trauma patient who had a repair. In my opinion, antiplatelet will be more than enough for this patient. Actually, now it's close to a month or 6 weeks, and the patient have palpable pulse. His limb is not swollen. Did not do a fasciotomy for him, and his nerve turned to be radial nerve injury, and actually he's having a physiotherapy and occupation therapy for that. Most likely he will recover. Thank you.
Thank you. So, Team Qatar, are you requesting final comments at this time?
Yeah. No,
Okay, very good. Thank you. And Dover, Dr. Alex, your final comments, please.
So this is, you know, it didn't sound to me that there was any problems with the axillary artery in terms of calcification or anything like that. So with regards to anticoagulation, antiplatelet, you know, with the good arterial repair and no issues, probably just antiplatelet would be okay. The vein may be more tedious and may give problems. So if you decide to do, you know, heparin IV post-op, I'll probably put it through the left antecubital and try not to overshoot. I did have personally a case with brachial artery and vein injury. I repaired both. I used saphenous vein for the brachial artery. I had the patient on antiplatelet only, and he did well. Thanks for a great case and another educational opportunity.
Thank you, Dr. Alex. In India, Dr. Venkat, your final comments, sir.
Excellent case and very well managed, and learned a lot from the case actually. Thank you for the sharing the case with us. Thank you.
Thank you, Dr. Venkat. Ryder, Dr. Poos, your final comments, please.
Yes, congratulations to Team Qatar. I like Team Qatar on the video conference here, and Dr. Rizzoli. I think this is a tremendous save. This patient came in an extremist, and your multidisciplinary team working together nicely, the trauma team and the vascular surgeons did a remarkable job to identify the injuries and did everything perfectly right, and you have a wonderful outcome and saved this patient's life. So congratulations. I also agree, I don't think you need systemic anticoagulation. I would give an aspirin. Even that is controversial. There's some literature which suggests that there's no difference in thrombosis rates with or without it in trauma. But I'm pretty conservative. I'm worried, so I would give him some aspirin, and that's it. But congratulations, a very well done job. Thank you. And I learned a lot today again. It was a wonderful conference this hour, and I learned a lot again. So thank you so much.
Thank you very much, Dr. Poos. Sao Paulo, Dr. Tele, your final comments, sir.
Yes, I have to congratulate for the comments. It's a very important case, a very interesting case, and the approach of the case. Usually here, the patients go to, all trauma patients go a prophylactic coagulation, because you have problems for with the repair of the artery, but you have all parts of the thrombosis. You can maybe some patients in trauma patients have venous thrombosis and embolus. So in the situations, usually you go a prophylactic heparinization of the patients when the patients are around 12 or 24 hours after trauma. So, and then there is no surround, the embolized surround loss control. So I believe it's a very interesting case, but I think we have to remember that the patients have, trauma patients have venous thrombosis and maybe embolizes, and thromboembolisms can become on a few days after their trauma. So in situations when we have very important manipulation of the patients, you have to make a prophylactic heparinization or anticoagulation. Thank you.
Thank you, Dr. Calais. Portland, Dr. Kasim, your final comments, please.
It was a very good case, and I would like to emphasize that you don't need a blood pressure of more than 90 in trauma patients while you are evaluating where the patient is bleeding. As far as the need for anticoagulation, if it is a single artery injury, I usually do not anticoagulate. But if it is a venous injury, I resort to what Dr. Alex has proposed, giving the anticoagulation through the same limb, just for 10 to 15 days, 10 days maybe, and then stop it. Thank you.
Thank you, Dr. Kasim. Dr. Marttos, would you like a final comment? Dr. Marttos?
Yeah, yes, can you hear me?
Yes, sir.
I have some internet problem in my house.
Okay.
Another great case from Team Qatar. Just to say, is not all that had the privilege to have like experienced trauma vascular surgeon available. So Dr. Rizzoli, Dr. Peralta, you have this privilege. Here in Miami, you would be able, we need to deal with this situation for the first half an hour, 1 hour. Maybe you could have vascular available, but it take like 1 hour to be here. That if it was Saturday 2 a.m., they're not in house. But I agree that the ideal is the injury, stop the bleeding. If you can shunt the artery, and then discussions could do a CAT scan or just do a to see that disclose any bleeding in the belly. So the definitive repair. Just remember, this patient may have like a brachial plexus injury. This patient may have like a non-functional arm also. So need to be sure that you treat the patient as one. And some people may be focused on the artery here and then forgot the patient may have like still abdominal injury. So need to stop the bleeding, control the bleeding, maybe shunt the arm, and then be sure that you're gonna find anything else. Go for anything else in the other cavities. Regarding after the vascular repairs, like Dr. Pu said, in Miami only use aspirin, unless there's something else happening. So Team Qatar, another great case, another great presentation. Yeah, it's an honor to have you guys presenting a case every month, and looking forward to the next ones. Thank you very much. And I will just finish saying, everybody, you're having a big problem in the world is COVID-19. South America, Latin America has been hit very hard. So Wednesday, we're going to have another webinar to discuss the situation. And some places like the United States are having a second wave coming. So the numbers are going up here in Miami, in Florida also. So we're going to start discussing the next webinars, what's happening in South America, and to share expertise between us and you guys in Europe and Middle East. If you're having a mid wave and how to face the second wave. Okay, thank you very much, everybody. Another great presentation. Thank you.
So thank you, everybody, for the opportunity, and thank you very much, Dr. Suhail, Dr. Hassan, for excellent presentations. Thank you for the opportunity. Bye-bye. Have a good night.